And I want to thank all the students for being here. I want to thank all of our panelists for joining us. I'll introduce them in a minute. I want to thank Yuri Yu and Christian Paget for helping us organize these sessions. I want to thank the Moynihan Institute for sponsoring them and Syracuse University for sponsoring them. We have Ben Mishkin, who will be our Q&A moderator. So you can put questions into the Q&A function starting now and throughout the panel. You can address them either to a particular panelist or the whole panel. And you can also like other people's questions, so those will come up to the top, and then Ben can pose them to a panelist or to the panel as a whole. So this panel, as I said, is going to address different research methods and COVID politics, and it represents a kind of a cross-section of all the methods, not all the methods, but a good number of the methods at the Methods Institute. We have Marcus Kreuzer. We'll be going in alphabetical order except for myself. I'll come at the end. We have Marcus Kreuzer, who's a professor and chair of political science at Villanova. He works on political parties, electoral and legislative institutions, and democratization in the 19th century, the interwar period, and post-communist Europe. Most recently, he's been working on the methodological underpinnings of comparative political historical analysis, with particular attention to various uses of time and history. And he's finishing a book called The Grammar of Time, using comparative historical analysis to answer macro-historical questions. Next up, we'll have Jennifer Larson, who's an associate professor of political science at Vanderbilt. She's an affiliate of the Vanderbilt Center for Data Science, as well as New York University Center for Social Media and Politics. And she's currently president of APSA Political Networks section. And her research is on how social networks affect political behavior. We also have a newcomer to IQMR, Christos Lynteris, who's a senior lecturer in social anthropology at St. Andrews. He's actually the only one of the panelists who's actually a specialist on pandemics. He's a medical anthropologist, and he focuses on the ethnographic and historical examination of infectious diseases, with a particular focus on zoonotic diseases. He's the principal investigator of the European Research Council project Visual Representations of the Third Plague Pandemic, and he's currently the principal investigator of the Wellcome Investigator Award Project, the global war against the rat and the epistemic emergence of zoonosis, 2019 to 2024. His recent works include Human Extinction and the Pandemic Imaginary with Rutledge in 2019, and he's co-author with Lucas Engelman of Sulfuric Utopias, A History of Maritime Sanitation. After that, we'll have Jonnell Robinson, who's Associate Professor of Geography and Director of the Syracuse Community Geography Program at Syracuse. Her research and teaching interests include community-based and participatory action research, and specifically participatory GIS, Geographic Information Systems. She collaborates with grassroots and community-based organizations to use geographic inquiry to better understand and address social and economic disparities, and she teaches courses in community geography, geographic field methods, and advanced GIS. Then we'll have Jay Seawright, a professor of political science at Northwestern. He's taught at the IQMR almost since the very beginning, and he works on causal inference, multi-method research, and the politics of representation with an emphasis on Latin America. I'll give my substantive remarks at the end then. I focus on case study methods and particularly process tracing and typological theorizing. Okay, so that's our panel. Again, you can start putting in questions now and throughout the panel. Please do so we can have a lively discussion after our initial presentations. Okay, with that, let me turn it over to Marcus for our first presentation.
Okay, so let me just quickly set the stage here for comparative historical analysis, because it's a very broad sort of methodology. If there's one thing that defines it, it's interested in big question. It goes back to sort of the 19th century, to scholars like Marx, Weber, and Durkheim, who were trying to understand sort of the advent of modernity. What all these scholars sort of share in common is they liked things in motion. They liked big historical phenomena, were interested in questions of historical changes over time, and put forth a whole series of explanations that were defined by their causal complexity. So the question is, what can comparative historical analysis bring to help us make sense of this COVID pandemic that we're currently facing? I'd just like to highlight three particular things. One is it brings a broader understanding of methodology. Two, it specializes in a wide range of exploratory tools that are particularly attentive to dimensions of time. And third, it is defined by four sort of archetypical sort of questions. So let me start with the first characteristic or contribution of comparative historical analysis, is that it employs a broader conception of methodology. So one way to think of this methodology is in terms of a research cycle, right? That most methodological approaches focus on steps 4 and 5, data collections and data analysis. And the other four steps of this sort of research cycles receive less attention. Comparative historical analysis, in turn, places a lot of emphasis on these exploratory, those are those three green boxes in this research cycle, on describing, finding patterns, conceptualization, and theorizing. And broadly speaking, what comparative historical analysis sort of tends to do, it puts questions before methods. It's really interested in coming up what are the relevant questions to ask. And once it identifies those questions, then it sort of kind of cobbles together the methodological tools that seem most appropriate in order to answer those questions. And so what it is particularly good at is exploratory tools. So let me just quickly,
Marcus,
so this is
sorry, will you be able to put it on full screen?
Oh, sorry. Yes. View. Oh, shoot. There we go. So this is a quote from, gives you a little bit of a flavor from Bernd Moore in the foreword, where he says, if one explores on foot, and at the present comparative historians do exactly that a great deal of the time, the details are what one learns first. Their meaning and relationships emerge only gradually. There can be long periods when the investigator feels lost in an underbrush of facts inhabited by specialists engaged in savage disputes about whether the underbrush is pine forest or tropical jungle. He unlikely is to emerge from such encounters without scratches and bruises. So I think what this sort of points out to is that this exploration involves some trespassing. You wade into different sort of disciplines, and sometimes that trespassing, encounters some, you get a lot of flack from different sort of directions. But in terms of exploration, okay. In terms of exploration, comparative historical analysis can be broken down into three broad strands: eventful analysis, longue durée analysis, and macrocausal analysis. And each of these approaches kind of has developed a distinct set of exploratory tools. So just give you an idea, eventful analysis, that sort of includes, think of American political development, historical analysis, the work of Kathy Thielen, or IR constructivism. And this eventful analysis really pays a lot of attention to events and description. It employs sort of the journalistics of who, when, where, and how, just trying to figure out what is going on, and uses that understanding in order to identify what some of the relevant questions are. Another thing that eventful analysis pays a lot of attention to is conceptualization, because it's not just interested in describing individual events, but comparing them. And for that, you need concepts. And the third thing that eventful analysis is very good at is periodization. It's interested in historical changes over time, identifying moments of continuity and discontinuity. And for this, it sort of uses periodization schemes. Long duration analysis, on the other hand, draws very heavily on time series data or panel data and is interested in identifying trends. And these trends usually have a longer time span than eventful analysis and are more cross-sectional. So long duration analysis is very useful for placing eventful analysis in a broader spatial and temporal context. Some examples of long duration analysis is the French Annales School, Douglas North, the whole literature on whether the West is different from the rest of the world, Piketty, and global history. And final macro-causal analysis is really less interested in describing, but in theorizing. It is trying to sort of figure out the causal pathways that explain cross-sectional variations. And it pays a lot of attention to elements of time like sequences, timing, tempo, and duration. And so these three sort of strands of comparative historical analysis, I think if we apply them to the COVID crisis, helps us ask very specific questions. So in eventful analysis, for example, you would use that if you wanted to find out exactly what happened to the federal response to the COVID crisis, right? I mean, we all know it was a mess, but it really would be helpful to have the chronology, the sequence of these events in order to sort of fully understand it and then maybe compare it to some other country. It could deal with conceptual issues. What exactly is a COVID death, right? I mean, there are a lot of back and forth. How do we count COVID deaths? So that sort of would be a conceptual question for which eventful analysis would be relevant. The third thing it would be helpful for is through historical comparisons. In what ways, to what extent is this current COVID crisis qualitatively different from the Spanish flu or the SARS? So those would be historical comparisons where you're trying to find out historical similarities and differences. Long durée, on the other hand, would look at broader sort of patterns of infections across countries and across time. It would focus particularly on the tempo at which these rates change, or it would ask to what extent are these trends, or do we have secular trends, or those seasonal trends, or cyclical trends? So it draws on time series analysis, a rich vocabulary for describing longer term patterns. Or it could place, for example, the COVID patterns in longer historical patterns of pandemics and see whether there are some interesting similarities and differences that emerge that help us generate some questions. Finally, macro-causal analysis would ask questions like timing. You know, to what extent, what role does the early infection in some places like New York have on the second wave infection? So it pays close attention to such questions of timing or the time lag. I mean, one of the perplexing thing about this COVID crisis is things are very asynchronous, right? And the fact that being infected 2 weeks ago might produce a death 2 weeks, that sort of time inconsistency is something that macro-causal analysis would pay great attention to. And then finally, it would sort of ask, what is the proper temporal structure for explaining some of these phenomena? So you could draw on Pearson's time matrix and ask, you know, are short or long short explanations the most relevant? So this is just some, give you some sort of sense of how these different strands explore and try to engage with empirical phenomena, and in the process come up with some questions that seem relevant and interesting. And just to quickly finish up, in terms of the question that comparative historical analysts tend to ask, they can be broken down into 4 broad categories: genetic, cross-sectional, historical, and ecological. Genetic questions, they try to explain the historical origins of a particular phenomenon. So for example, what caused the First World War? What caused the end of the Cold War? So these are questions that are trying to retrace the generative process that brought about a particular historical event. I call those genetic questions. The cross-sectional questions Those are the most widely asked questions in comparative historical analysis. Again, think of Barrington Moore, the Colliers, or Mahoney. You have cross-sectional variations, and then you provide some historical explanations. Historical questions, those are the ones that are interested in qualitative changes, right? You know, how is the past present from the present? Trying to find out historical continuities and discontinuities. And the ecological questions are the most complex ones, where you try to explore how are different historical phenomena entangled with one another and interact to explain complex outcomes. So these are some of the questions that you can use in order to just start engaging with this incredible complexity of a phenomena like the current empirical, the pandemic crisis. Okay, so that's all I have to say. Thank you.
Oh, great. Thanks, Marcus, for a very concise overview. Just two reminders, you can put in Q&A anytime into the line there. And also a reminder, I forgot at the start to mention, this will be recorded so you can access it later as well. So we're going to check on getting slides available, but you can see them through the recording that way as well. Great, let's turn to Jennifer Larson then.
All right, well, thanks everyone, and thanks for including me in this fascinating panel. I'm going to talk about networks approaches to studying COVID. And networks approaches to studying anything begins by acknowledging that actors are not independent from one another. And so it aims to figure out exactly what dependencies or what relationships among actors might matter and how they might matter. So let's think about social networks, and any network is defined by nodes and links. So think about people as nodes. Then the next step is to figure out some relationship between pairs of them that are going to count as links. And once we have all of the links present, based on the definition that we've specified, we get this nice constellation of links amongst our nodes that creates a picture that is a network. And different networks can have different shapes with different meanings and consequences. So just to make sure we know what to store in our head to think about this, these are just 3 example networks, all of which defined amongst me and 17 of my colleagues in Vanderbilt's political science department. The top left is a network where links are defined as marriage. For instance, my husband is also a faculty member of the department, and there's one other married couple, so there's 2 marriage links in our department. The top right is the network, still amongst the same 18 of us, but this time the links define who is co-authored with whom. And in the bottom, we can define links amongst the 18 of us as meeting co-attendants. And since all of us have shown up to a faculty meeting with all of the rest of us, all possible links are present. So those are based on different definitions, different shapes emerge of networks. So keep that kind of thing in your head. And let's think about 3 networks that are particularly relevant to trying to study COVID. And I'm going to call these a contact network, a trust network, and the esteem network. So first, let's take a contact network. And let's define a link as an encounter between both of the nodes, both of the people we care about, where that encounter happened within 6 feet of one another. So these links we know are especially important when we want to think about COVID, because these kinds of encounters have the possibility of actually transmitting COVID if one of those nodes was infected to the other one. Thinking about this in a networks approach is really fruitful, because not just the presence of these links matters, but which links are present and how these links are arranged is really important, because it determines how widely COVID might spread through some set of people we want to think about. So think about a person who is connected in this sense, so has encounters within 6 feet of some other people, who themselves have encounters within 6 feet of other different people, who encounter other different people, and so on. This kind of network would describe a situation where COVID could spread really widely to lots of different people. And so, thinking in these contexts, we can think about, for instance, how to design campus plans. If you think about a typical day of a college student on a campus that's doing nothing about COVID, the typical college student encounters lots of people within 6 feet. They probably live with someone, they might share dorm showers with one another, bathrooms with one another. They go to class, maybe they don't go within 6 feet of everyone in class, but doorways are narrow, they encounter some, they sit near some. Then they go to a different class and encounter lots of different people within 6 feet, then the lunchroom, then a different class, then a club. And you could have networks on college campuses, even just for a day's snapshot of who's within 6 feet of whom, indicating that COVID could spread spectacularly widely. So with this picture in mind, campus plans for bringing students back safely can try to transform what the network would look like, can try to fragment it, for instance. So you hear plans of planning to commit students to something like germ communities, where, okay, you and these 7 other students can be within 6 feet of one another, and you're gonna take your classes together or take your classes online in the same room, and you can socialize with them, but no one else. If that worked, you would just have little pockets in the network of size 8, and in principle, COVID couldn't spread beyond it. But then you would want to think, in the crazy situation where undergraduate students don't comply with the rule that says don't party, don't hang out with one another, don't date anybody outside of this community, in such a situation, any new link that gets added brings with it possibly the germs of 7 other people, and any other people that maybe those 7 other people, in total 8, had encountered because of other violations of policy. So we can start to think about network shape and how it would matter. And the shape of networks of contact and encounters is also really important when we want to think carefully about when herd immunity is achieved. And I'm happy to chat more about this in Q&A. I suspect we might hear more about this from the other panelists as well. And thinking about exactly who would be the most valuable recipients of a first vaccine. So once we have a network shape in mind, are there some people who would encounter lots of other people who aren't yet infected? Or are there some people who sort of bridge communities in the network, one community over here, one community over here, and if this person were immunized, the disease at least couldn't jump, the virus couldn't jump from one community to another. Having these shapes of networks in mind can be really helpful. The second network I want to think about is a different kind of network. Let's call it the trust network. Think about defining links in the network in terms of who trusts information they hear from whom. We know a lot of information gets spread socially. People chit-chat about news, they share news information on online social media, but people who hear things from just anyone don't necessarily believe it from just anyone. People in general have some set of their social ties that they especially trust, and that if someone would tell them information, they're likely to believe it. So have this kind of network in mind. And with this network in mind, this is important because links in this kind of network might really transmit information, and information is especially important in a pandemic, like where it is, like how it's spreading, like what safe practices are. And how links are arranged in this network, the shape of this network, is especially important because it can determine how widely any one piece of information can spread, how many people it might ultimately get passed on to and believed. Also, how many different bits of information, how many sources a person is exposed to, and crucially now, whether false information is ultimately countered by truth, and countered by truth from someone who a person believes. So thinking about this network and its shape is especially important for thinking about public health information campaigns that are just trying to spread factual information, like there's a mask mandate now, so wear a mask. It's also important as we try to understand how misinformation can persist. If people hear that a mask can be helpful, but people also hear that wearing a mask is dangerous because it somehow makes you breathe contaminated air behind the mask, which one do people believe? They've heard both. But if we really understood who a person trusted more, and their trusted social contacts warned them that this is dangerous, that can help us understand these pockets of misinformation and its persistence. And thinking in these terms can lead us to important policy levers, especially in places where we know a lot of information is getting shared, like online social media platforms. The third network that I want to think about, I'll call the esteem network. And by esteem, I mean, let's think of a link as indicating who shows off for whom, or whose judgment of your behavior do you especially value and care about. Links in this network are important because they're the links that can transmit peer pressure, social pressure about how one is to behave. And the arrangement of links in this network is important because it determines not just what a person hears, but how a person is ultimately going to be judged for acting on the information they've received so far. And so if we want to understand why it can be that people can all have heard information that they should be wearing masks, have heard information that they really shouldn't host parties, birthday parties, weddings, in big group gatherings indoors together right now, and yet people are still doing this, it's really helpful to understand the networks that are making it possible for some people to act a certain way and be socially rewarded for it, and other people can act a different way but be socially rewarded for it. If we could really understand and identify these networks that determine who gets rewarded for what, we could better understand the behavioral mediator between information campaigns and ultimate compliance or behavior. And I'll just raise that this kind of network is also important because even if a person thinks I would prefer not to hold a meeting that I'm supposed to call in person, but I've come to believe that people in my esteemed network, they might not think of it in exactly those terms, I've come to believe that other people don't value meeting online and in fact prefer to meet in person, and I suspect all the meetings they're going to call are going to be in person, then even though I would prefer to hold mine online, maybe based on what I know other people are doing, I should hold mine in person as well. So these networks can also shape people's expectations about what others are planning to do, which can alter their behavior, and again explain how we get departures between straight up sending information to people and what people actually do to act on it. So this suggests that if we wanted to really study behavior in the age of COVID, there are some things we would want to do. We would want to especially pay attention to what the relevant networks are, ideally measure them, and especially theorize about them when it comes time to do things like plan a campus policy, decide various public health measures. We know there are lots of surveys underfoot. There's lots of questions that are quite simple that we could be asking to really get at these mechanisms that we know are probably at play from the study of networks. And all of this would really help us understand how people's social experiences and their social networks can moderate the impact of information on ultimate behavior that could be really important in a pandemic. So with that, thank you all very much for listening. I look forward to the Q&A, and I'll turn it over to Christos, unless Andy has something to add.
Thanks, Jennifer. Clearly very relevant. We're all waiting to see how professors rank in the priority when there's a vaccine.
Very true.
First responders are going to be ahead of us as they should. Christos?
Yes, good evening, and thank you very much for the invitation to present on ethnographic methods. So in terms of general introduction, ethnography is the main method of social or cultural anthropologists, but it is also a method that is being increasingly used by other disciplines. In its ideal form, it involves the immersion of the researcher in a given community for a period of engagement with this community through the method of what we call participant observation. Now, usually this involves something between 12 and 18 ideally uninterrupted months, meaning that you have to stay there and not go home. And it requires the researcher to engage in the daily practices of the community, whatever these may be, as well as with exceptional or periodic events such as deaths or ritual practices, with no option of opting out of any of these. Now, in reality, of course, the way of engagement or participation depends on the subject of study. So this would be different, for example, if the researcher is focusing on weaving, on shamanism, or in research on animal sacrifice. And in reality, beyond the mystique of anthropology, the researcher is never immersed in the community as such, but rather only in a segment of it, and the main bulk of information usually derives from a limited number of informants with whom the researcher establishes relations of trust and a more constant interaction. Now, since the 1980s, anthropology has been one of the most self-reflexive and self-critical disciplines, and as a result, it has systematically critiqued and tried to overcome the methodological and epistemological problems arising in ethnographic research as this was defined within the colonial frameworks in which anthropology arose. But also it has tried to address the inequalities that this research depends upon and perpetuates. The result is a refocusing of ethnographic methods towards an understanding of societies and cultures where both the questions and a good part of the analytical frameworks or tools are driven by the informants rather than the researchers. So while, say, Malinowski in the 1930s would go to his field with a set of theoretical questions or theoretical tools already forged back in England, and nowadays we try not to do that and for these to be forged in collaboration with our informants in the field. Now, ethnography can be an end in itself, or it can lead to comparisons between societies and cultures. Over the decades, this has enjoyed long periods of popularity and non-popularity, with the apogee of the former being the years of structural anthropology in the 60s and early 70s. Now, after many decades in the wild, comparison is back, with leading anthropologists in France, Brazil, and elsewhere having tried to reforge comparative methods, freed from the theoretical burden of structuralism, with great success, particularly in comparing human interactions with non-human animals. Now, within anthropology, there is a flourishing subfield, which is known as medical anthropology, and this focuses on the study of health and illness, as well as medical practice. Whereas this traditionally focused on non-Western ideas and practices, over the past 50 years or so, medical anthropology has come to study biomedical systems in a systematic manner, and at the same time to contribute to understandings of the social drivers of illness in industrialized contexts. Now, as regards COVID-19, the vast majority of universities in Europe and the UK have banned person-to-person research and all work-related travel during the pandemic. And as a result, by contrast to other recent epidemics such as Ebola and Zika, there has been little ethnographic on-site research on COVID-19. But research is now being allowed once again, and travel restrictions are being relaxed, so ethnographic research is about to resume. So what does this consist in relation to an infectious disease epidemic? Now, since the early 90s, medical anthropologists have turned their attention to the study of epidemics and epidemic response. And there are, we can say, three ways to simplify things in which ethnography is used in relation to epidemics. Now, first, ethnography, which has been collected outside the context of an epidemic emergency or an outbreak, namely before it, in a given region, can be used in order to understand transmission pathways, risk factors, but also community responses to epidemic response in that region. So, for example, if you're an anthropologist with knowledge of burial rituals, you can provide information to medics on contact patterns between the living and the human corpse. How does a given community treat the human corpse? Do they wash it? How do they bury it? Do they cremate it? And hence they can explain, to use an example, an actual example, how, for example, in given communities in West Africa, or why these communities resisted epidemic control measures that required the interruption of traditional burial rites and their replacement by hygienic burials. Anthropologists can use this previous knowledge in order to explain present patterns during an epidemic, even if they have no medical anthropological training. Now, second, ethnography can be conducted in the midst of an emergency, such as an outbreak or a global pandemic. And this is when anthropologists are called to the field or manage to get permits to go to the field in the midst of a crisis. And there their role is mainly, to be very frank, one of mediation between medical staff and the affected communities, and to a lesser extent, a gleaning of information that can be used to facilitate epidemic response more generally. Now, in this context, then, anthropologists act as advisors to national or international response coordinators, such as the WHO, and are very often catalytic in fostering community-led epidemic response. So they're advocates as well. They're advocates of kind of horizontal approaches rather than top-down approaches to epidemic response, again, with great success in some parts of West Africa during the Ebola epidemic. The problem or limitation, let's say, of this research is that the time frame available to the ethnographic researcher in this situation of emergency is not one which is optimal for ethnography. As I mentioned, ethnography is something that needs to last for a year or 18 months. And usually in the context of an emergency, you only have a few weeks or maximum a couple of months. And definitely you need to process this information and come to conclusions much faster than anthropologists are used to. So usually this works well if the anthropologist has previous experience in an affected community. So if an anthropologist has studied a community where there is an outbreak, and then returns to that community to do some extra work, some extra research. Now, this could be a medical anthropologist or not. It's not very often that you can find exactly the expert you need in these cases. So in most cases, it would be a non-medical anthropologist that could be recruited for this purpose. Now, in both case 1 and 2, which relate to epidemic response as such, the contribution of ethnography is often seen and valued as one of cultural translation. Now, underlining the importance of examining this process is the fact that often epidemics occur in underprivileged regions of the Global South, where first-hand ethnographic data about societies affected by the epidemic constitute rare resources of vital significance for both understanding transmission pathways, the broader social ecology of the disease, and the optimal way in which the epidemic may be collaboratively contained in ways which are least harmful to the social and cultural fabric of the affected communities. So in this context, ethnography's advantage lies in its examination of the local and the global within a single framework. Both the local and the global have a life of their own, but they also interact, creating new sites that need to be studied. And ethnography, with its focus on problems of translation, can highlight how such interactions can have unintended consequences. Now, the third way in which ethnography can be involved in the study of epidemics is through the study of the longue durée of epidemics, or within an ethnographic framework of the longue durée, so several, say, decades, or if someone is very committed to this. And this can involve research in areas where a given disease is either endemic, like, say, plague in Madagascar, or where scientists expect new diseases or new disease strains to emerge, such as the case of Ebola in the Democratic Republic of Congo. In this case, ethnography will focus on human-animal interactions and material proximities as infection drivers, and more broadly on the social ecology of disease maintenance, transmission, and emergence. But it would also focus on social inequalities, on patterns of access to healthcare systems and networks, and more broadly on the structural drivers of illness in a given region. Another focus of this type of ethnography would be post-pandemic conditions, where the ethnographer would study the after effects of an epidemic or pandemic. What happens to survivors and their families? Are there patterns of stigmatization in individuals or communities that have been affected by the epidemic? What patterns of post-pandemic behavior emerge in a given society? The ways in which human and non-human interaction may change as a result. Now, within these three kind of pillars of ethnographic engagement with epidemics, we need to keep in mind that medical anthropology, of course, aims at something much broader than simply an explanation of what are the transmission pathways of a given disease. It has other theoretical, if you like, aims of its own, and yet in an applied way, it is a vital tool for epidemic response and preparedness, but also for understanding the long-term or mid-term drivers of disease transmission, emergence, and maintenance. Thank you.
Thank you. Let's hope that the emergency doesn't become 12 to 18 months. You may be in your categories there. Jay?
Thank you. So I'm going to talk about the role of natural experiments in the study of, well, basically the COVID crisis. I'm calling it the emergency because the fact of the matter is that what's happening right now is a lot more than just one thing. So there's the meme that's been going around on the internet of the year 2020 on the left, and what actually, my plans on the left, what actually happened on the right. I've shared my personal favorite one of this. I think this is certainly how most of us feel. This has definitely not been the year nearly anyone planned on having. In many different ways. We definitely have an ongoing crisis in terms of the pandemic itself. So there is this, self-evidently global spread. In the United States, where I'm at, it's a very much a local problem. Illinois, very much more locally where I am. We had a big first wave that we didn't quite ever get under control, and it's creeping back up, and it makes me very anxious. Brazil, where I like to spend a lot of time, is going through a miserable situation. So the fact is, lots of people are getting sick and dying in a way that didn't happen 12 months ago. This was a disease that just wasn't present in human populations, as far as we know, even in October, November last year. So there's this new disruption of our health systems. Alongside and as a consequence of that, we've also had an extraordinary global economic decline. By most estimates, this will have been the most destructive year for the global economy since the Great Depression. It may not be permanent. It may not last as long as the Great Depression. There's a lot of dispute and argumentation and all kinds of models and predictions and forecasts. But what we can say right now is that there's an economic disruption that, globally speaking, is larger than anything any of us has ever lived through. At the same time, we also have the largest instantaneous reversal of globalization in many, many decades. The total amount of travel worldwide has plummeted. The amount of goods crossing borders has dropped more than in any time since the 1970s. We are in a situation where one of the signature trends of the 1980s through last year has suddenly and abruptly reversed. At a more micro level, we are all experiencing unprecedented changes in the way that we work, go to school, and so forth. My children have loved working online to do their schoolwork because they can get it done in about 2 hours. I'm not sure what that tells us, but it is something they weren't able to do before. I am not very happy with having to be giving you this presentation through the internet. It's an awful lot more fun to see you and hear you, but I can't. This is the world that we're now in. Because of all of the changes I just listed, there are massive disruptions to policies, healthcare policies, sure, but also transportation policies, education policies, budget policies, tax policies, and so forth across the board at all levels in the United States, Europe, and the developing world. In the United States in particular, we had the simultaneous or virtually simultaneous eruption of massive racial justice protests, state repression of those protests, and now we're onto a kind of meta cycle of protest against the repression and repression of the protests against the repression. All of this essentially at once. This is a problem for us as social scientists, because in order to study a natural experiment, there's a lot more to it, but there are two key conditions that we need. We need a shock that is random or as if random, something that's unpredictable and comes from outside the normal sort of system of social and economic interactions. I think by any accounts, the emergence of this disease would count as that. Certainly people have predicted the emergence of pandemics, absolutely. Even pandemics with many of the traits we're experiencing. But the fact that it was going to happen this year was quite unpredictable for most experts. People didn't see it coming right now. So that's nice, that's a nice shock. The other thing we need is a clearly identifiable treatment. We need there to be one key variable that's manipulated. This year, as I just went through, we have many variables manipulated in world historical ways, easily dozens of different treatments. The downside to this is, if we're not careful, our causal inferences may pick up the effects of more than one of those variables at once. Oh, I'm sorry, okay, yeah. More than one of those variables at once. And therefore, we may confuse ourselves and our audiences in drawing causal inferences that are inappropriate. The effects of the economy may be treated as the effects of the disease. The effects of reduced travel may be treated as the effects of social protest, and so on and so forth. How do we get around this? We need to think small. And this is usually the opposite of what we all like to do as social scientists. We like to ask big questions with enormous implications and consequences. We need to focus in on small, tight comparisons, because the only way we're going to be able to isolate one, if we're really lucky, or maybe 2 or 3 strands of the disaster that is 2020, is by focusing on small changes, local comparisons, and tiny movements in these events. The overall processes are so simultaneous that they're inherently entangled. So we want to look at little moments and little movements that let us separate one of these things from the others. And I have a few examples of these that I'd like to talk about kind of quickly that do, I think, interesting things. In answering the big question, do mask mandates work? Now, I'm going to take it for granted we're all sort of enlightened people and we believe that masks are good. If not, please just do it anyway. But okay, fine. The question I am asking isn't so much are masks good, but is the social policy of requiring masks useful? And actually, an interesting question is useful for what? An initial question we could ask is sort of what happens, do people actually wear masks when the government tells them to, right? Does a government mandate change behavior? And we've got a set of folks here from across a whole bunch of disciplines, communications largely, but other disciplines, who put together a natural experiment to try to look at this. What they focus on is in the United States, there had been advice not to wear masks unless you were essentially a healthcare worker or a first responder until the evening of April 3rd. On the evening of April 3rd, the Centers for Disease Control and Prevention recommended that Americans wear, cloth masks that we could make ourselves or buy at the store. And the president mentioned that recommendation on his press conference event on the evening of April 3rd. So there is a disruption in the message people are getting about masks that happens on the 3rd. So they want to compare, in a survey that was in the field starting a few days earlier, they want to compare people's responses in terms of, a bunch of socially relevant, social distancing relevant behaviors before and after the 3rd to see if there's a difference. So we can see immediately there's almost, from the 3rd to the 4th, we see very little change. But from the 3rd and the 4th to the 5th and the 7th, we see a significant change in mask wearing behaviors, but not much change in most of the other behaviors, which is good. If we saw a change in everything, we'd be worried, right? If people started staying home more because there was a mask order, then maybe we're not picking up the effect of the mask order. But by focusing in on less than a week of time, right around this event, we're maybe getting a clean estimate of the effect of a mask recommendation on people's willingness to wear masks, which seems to be around 7% or something like that. Now, as a case study researcher, we might worry and say, could other stuff have happened at the same time? And the answer is obviously yes. So for example, if we go into Google News and search around April 4th, the number that, here are the top 3 results in Google News on a anonymous profile for that date. So there's something about the sequencing of the genome, what the coronavirus bill means for Michigan, what peaks, lockdowns, and testing mean, general news from April 3rd, a coronavirus hotspot near New York City, and the update from the FDA that includes some information about the mask mandate. So what we can see is, in fact, the news is not heavily emphasizing the mask mandate at that point. It is heavily emphasizing what we can see as the gigantic, enormous growth that was right in the middle of the late middle of the growth curve of coronavirus in the United States. The scary nature of what at that time seemed to be uncontrolled spread was getting a whole lot of attention. And there's ambiguity, actually, in how we interpret this. Are people reacting to the mask mandate, the mask recommendation, by adopting masks and social distancing? Or are they reacting to the scary upward trend in cases per day that was nearing its peak by adopting masks and social distancing? This study really can't answer that for us very cleanly. And it would be nice to have additional information. This is hard, right? It gets us somewhere. It narrows things down. It's definitely not the economic collapse, which came a little bit earlier. It's not the breakdown in travel, which came much earlier. It's not the social justice protests, which came later. But it could be a few different features of the pandemic. So maybe there are other comparisons we want to make. So Liu and Weiby compare before and after mask mandates were signed in the states that have mask mandates and compare them to the states that don't have them. So if we look through the chart, we're looking really at the left column. The ones for employees is not as interesting. But the general public, do you have to wear a mask when you're in public? And we can see that during spring of 2020, around half of the states in the US imposed a law requiring people to wear masks. If you go through the list, you will see that the great majority of those states, not all of them, but the great majority of them had Democratic governors. And the great majority of the states that didn't impose mask requirements had Republican governors. So there's a worry as to whether this is random variation, right? If it might be partisanship expressing itself in some way. But we can compare before and after, and when we do, we find, and here we're seeing the transmission rate of coronavirus rather than just behaviors of compliance. We see that the transmission rate of coronavirus goes down by around 1% per day in states that have a mask requirement compared to states that don't, and controlling for prior trends. So this difference in differences design, which takes it as a random event that you have a mask mandate, gives us some reason to believe that mask mandates, in fact, substantially reduce the spread of the disease. If we believe that it's random that a bunch of Democratic governors passed mandates and the others didn't, okay. So maybe we want a tighter comparison than that. So in Germany, we have a set of social scientists and epidemiologists who compared a much tighter comparison. They look at the city of Jena, a town of about 100,000 people that had an obligation to wear masks much earlier than in the rest of Germany, about 3 weeks earlier. And so the question is, sort of, do we see a drop in Jena's spread before we see that drop in other places? And then the question is, why Jena in particular? I don't really know. It's just weird. Jena shows mask was their slogan, which I guess probably sounds better in German. Okay, but what we can see is that Jena's rate compared to a synthetic control, which is a kind of weighted average of most of the rest of Germany to try to become an exact parallel for Jena, which, all right, we can worry about that statistically some other time if you want. Jena's rate drops off substantially. The spread of new cases really drops almost to zero after their mask mandate goes into place. And it drops off significantly before the drop off for the rest of Germany, which if we were to extend this out, I'm sure you all know, drops to zero very shortly after their mask mandate. So we do see a real movement here where this city, which had an early move to have a mask, really sees a bigger change than even other cities with the same kinds of governments and same kinds of political situation in Germany. On the other hand, in comparison to the US study we were looking at a moment ago, we're now really relying heavily on this city of Jena. And if there's anything weird about that city at all, our entire natural experiment gets blown to bits. So the thing I'd want to do here is to learn an awful lot more about Jena and use that to justify this. The natural experiment is going to be really hard to justify without a lot more in-depth case knowledge than these articles tend to give us. We need to rely on these smaller comparisons because the bigger ones are hopeless right now. Everything's happening at once. But the smaller comparisons need a lot of knowledge of the specific cases we're discussing, or they won't work out. Now, the kinds of dependent variables I'm looking at are maybe even easier than they are for social scientists here. It's pretty easy to understand how masks control the spread of a virus, online idiots notwithstanding, right? It's much harder to understand the kinds of things that people are going to end up using this for. When we look at the spread of mask mandates and stay-at-home policies as instruments that are going to feed into social relationships we care about for other theoretical reasons. The set of assumptions that are going to be needed to justify those other claims will be hugely more controversial and harder to justify. So the challenges of case knowledge and focus that we face in understanding COVID-related questions are only going to expand when we try to use this unusual and world historic event to study other things. And it really is hard for me to solve those problems for you, but I will leave you with the please wear a mask. Thank you.
Thanks, Jay. Let's see, I got mixed up in the order, so we're gonna go to Jonnell Robinson. Apologies for getting that in reverse with Jay. Go ahead.
Give me 1 minute to set up my screen. Okay, can everybody see my cover slide screen? Let's see, of course I can't see you. Yes, okay, great. Well, thank you all for including me and allowing me to learn so much about various methodological approaches to studying COVID. Again, my name is Jonnell Robinson. I'm here at Syracuse University, and I'm going to talk a little bit about how GIS and spatial analysis have been used to study COVID-19 so far. And I'm going to really stick with a high-level overview and answer questions afterwards if they arise. Well, as I'm sure you all know, geospatial data has long been used to track diseases. And many of you have probably seen these iconic maps created by John Snow in the 1850s, which enabled him to identify the long misunderstood cause of cholera outbreaks in London. By mapping household cases, he was able to hypothesize that cholera was a waterborne disease and not caused by bad air or miasmas. So in the 1850s, you see some very rudimentary maps that use data from at the household level to show deaths or illness, and then by aggregating those data, he was able to start to look at different environmental contaminants or environmental exposures that might be causing those types of diseases. So we've come a long way, obviously. Internet and big data allow for digital, interactive, and real-time maps to be widely and instantaneously distributed across the globe. And with the COVID-19 outbreak, we've seen a variety of dashboards like this that's been produced by Johns Hopkins University to show a variety of data related to case counts, death tolls, hospitalization rates, and other sorts of measures. Now, these data are largely being kept in geographic information systems, which stands for GIS, and really, at the basic level, this is a framework for gathering, managing, and analyzing data. GIS as a software now have a variety of technologies available, including open source technologies like QGIS and R for mapping, or some of the more traditional proprietary software programs like ESRI or Esri. So it's a broad term that can refer to a number of different technologies, processes, and methods. And it has applications in planning, engineering, business, transit, and of course, public health. And within GIS, what is useful is that we can link locational data to tabular data that is typically stored in a database to enable spatial as well as spatiotemporal analyses. So GIS can provide us a perspective on data that can't be easily seen when you're extracting large amounts of data from tables. So the other useful thing with GIS is that you can integrate a variety of disparate data from different sources and layer those data together to look for patterns, relationships, and trends. We see GIS being used with COVID-19 to reveal problems, to monitor disease change, to manage and respond to certain events like hospital bed shortages and setting priorities, and then also using that spatiotemporal data to forecast interventions into the future. So the study of epidemics and diseases within public health has, as we've seen, over 150-year history, and there's a variety of texts. I've mentioned 4 here that if you're really interested to learn more about the methodological approaches with using GIS to study disease, I recommend The Geographical Structures of Epidemics by Peter Haggett, Spatial Epidemiology, and then of course there's tutorials that have been put out to use the software to manipulate GIS public health data. So thinking specifically about GIS and COVID-19, data processed with GIS and spatial statistics are critical in the study of COVID-19. I'm sure many of you are on a daily basis reviewing maps of your state or your country to get a sense of hotspots and clusters and to figure out more whether or not diseases, the impact is on the rise or on the decline. So with GIS, we can take important indicators and visualize them in maps and reveal geographic aspects of the pattern. And the most recent published studies examining the use of GIS and spatial analysis as applied to COVID-19 really point to aiding in decision-making as the ultimate use and outcome of using GIS at this point. So some of the broad areas where GIS is being used with COVID-19, communicating real-time disease data to policymakers and the public. This is where you see your maps of total cases, numbers of deaths, total hospitalized, or the test positivity rates. Spatial modeling is also used to forecast the outcome of different policy measures, such as social distancing and medical resource demand. And these first two bullets really indicate a relatively quantitative approach where you're looking at using spatial statistics either in conjunction with or within GIS. That third bullet, GIS allowing researchers to overlay disparate data sets to examine population level correlations between COVID-19 and disease risk or social vulnerability, has also become really important. As we know, coronavirus affects different groups with varying levels of severity, and some communities have a disproportionate share of the population with health conditions that make them more vulnerable to the adverse outcomes of COVID-19 infection. So those maps that overlay existing data from the Census Bureau, for example, on poverty or low-income households or language spoken at home can be integrated with COVID-19 disease maps to project risk in certain areas of the world or within the US, for example. And GIS mapping has also been used to visualize resource allocation and the lack thereof of resources. And I'll show a few examples of this in a moment. And then finally, different branches of GIS, including participatory GIS and qualitative GIS, use crowdsourcing and allow end users and participants to contribute valuable data in the fight of COVID. So I just wanted to walk through a few examples. This first map is a map from the New York Times and their database that reports COVID cases on a daily basis down to the county level and all the way up to the scale of the globe. These are the most traditional real-time disease data sets that are scooping up data from a variety of sources from the WHO, National Institutes of Health, and reporting out on case numbers on a daily basis. Canada's COVID-19 health dashboard uses small area estimates from Canada's Community Health Survey to classify risk by comparing the population of people age 70 plus to the overall population density in this example. So many of the dashboards that are being produced not only show disease prevalence and incidence, but they also integrate those data to show some indication of vulnerability and risk within populations. And most of these maps are interactive, so they allow users to zoom into any province within the country and view their own communities. The Centers for Disease Control in the US has also created social vulnerability reports for every county in the US, integrating a variety of data, including elderly households that are low income, and also indicates the number of resources available, including things like licensed hospital beds. And several communities have created online interactive maps to share information on where to find important resources, such as free food and COVID-19 testing. So just to get into a little bit more of the qualitative methods of GIS, I'll talk a little bit about public participatory GIS or participatory GIS. PBGIS often refers to the approaches that are used in order to make GIS and spatial decision-making tools available and accessible to all those who have a stake in official decisions, but who might ultimately be marginalized because they lack access to the technology or the sophisticated tools that are used to make disease mapping. So within geography and GIS, there's a large movement among researchers and practitioners to make GIS technologies more widely available across populations. In terms of qualitative GIS, this really talks about how we might integrate different types of data into a GIS, where we typically think that GIS can only deal with numerical data. Qualitative GIS thinks about how we integrate qualitative methodologies like focus group, interview, observation data into a GIS. And I have an example here from a study that we're working on right now with some school districts and the Tug Hill Commission in upstate in northern New York, where we have a lot of rural communities that have very minimal access to broadband services. And now that we are learning and teaching and using telemedicine from home, it's critical that we have good broadband access across our country. So these maps are an example of us sending out paper maps to superintendents across school districts and just asking them to use a marker to mark up on a map where they think there are certain types of broadband access and where they think there's no broadband access, so that we can use these data to advocate for policy change and some efforts to expand broadband into those areas. Crowdsourced mapping has also been used on a more limited basis in the COVID-19 outbreak. Crowdsourced mapping we also refer to as volunteer geographic information, or VGI. And essentially what VGI pretends to do is break down those divides between expert and non-expert in creating and serving maps to the public. So in this instance, we now have, with all the different open source technologies and out-of-the-box programming, much more ease of use of some of these mapping technologies. So almost anyone can create sophisticated maps displaying COVID-19. And crowdsourcing as a proposition really takes into consideration the fact that we might be able to hone in on either solutions or have a better understanding of a problem if we have multiple people involved, and that their collective expertise can sometimes parallel the expertise of one individual expert. So we see a number of crowdsourced maps that have cropped up, often which utilize apps that have been developed for people to report their own symptoms. And then this asserted content is compared with authoritative content from established organizations to see if there are new outbreaks emerging in areas where we don't have authoritative data yet. So all of these types of maps rely on some pretty simple techniques. And I wanted to talk just briefly about geocoding, which is one of the most common aspects and most common tools used within GIS. And that's essentially transforming location description, whether or not it's coordinates, a street address, a zip code, or a country name, into data that can be mapped in a GIS. So ultimately, with disease cases in the US, we're seeing how home addresses of individuals are reported to their health department. Those addresses are then geocoded and then aggregated to a number of political or statistical boundaries and distributed or disseminated for further analysis. So geocoding is the foundation for so much spatial analyses. In order to do buffering, density, cluster analysis, hotspot analysis, it all requires to start with geocoding. And then from there, this is what it would look like with just an address list in tabular format. And then those data are entered into a GIS and turned into maps. And then the second process that's really important is to go into a spatial join, where we aggregate point data to polygons, or a one-to-many relationship. And this is what you mostly see. We don't see individual cases of COVID-19 mapped. We see aggregate cases that are mapped typically to some kind of a political boundary in order to protect anonymity and confidentiality, but allow us some ability to do some geographic analysis. So some of the methodological challenges, and this is just a brief overview, there are so many more, but balancing privacy with public awareness. You may have seen articles that people talk about the maps. They'd really like to get to more granular levels, but in order to do that, we're breaching privacy. So most of our maps represent aggregate data to political boundaries. And as we know, diseases and epidemics know no political boundary in their spread. There's also been a good deal of contention around data definitions, and underreporting and unequal reporting are certainly a huge phenomenon. And so our maps are really only as good as the data that we have available. And we know that in under-resourced countries and communities, we may see underreporting or misreporting of cases. And then finally, cartographical errors and misrepresentation of data. In this data-driven world, there are many ways to get involved with using GIS and mapping, but oftentimes the training might not be there. So simple errors can lead to really large misrepresentations and confusion. I'll just give a quick example. These maps were produced by Kenneth Field, who's a renowned cartographer. He published an article on Esri.com in February discussing that we need to be responsible when it comes to mapping COVID-19. And he talked about a variety of issues ranging from map projection and the fact that when we use the wrong map projection, we can make areas that are small look much larger and more problematic. And he also talked about the ways in which we map total counts for data. So for example, in this red map on the left-hand side, not only does it use a bad color choice, red typically connotes emergency and fear. But you see that here we have Hubei province that has over 65,000 cases, but it's indistinguishable from its neighbor provinces in China that had much fewer cases. So better maps in terms of choropleth mapping are those that normalize by total population, and even better yet, get away from the standard choropleth map and use dot density maps. So there's a number of different techniques within cartography that can also be problematic methodologically when using GIS. So I'll just conclude there to say that GIS and spatial statistics are certainly very important to the study of COVID-19, but I want to recognize that stopping the pandemic requires an interdisciplinary approach with a global perspective. GIS combined with the methods, some of the methods that we've talked about here today, are probably going to be our best chance for stopping COVID. Thank you.
Thanks, Jonnell. It's clear that GIS has never been more important. I think all of us have been consulting it a lot in recent weeks and months. Let me just say a few things about case study methods in COVID, and then we'll have some time for Q&A here. Just going to screen share. So case studies have already contributed a lot to our understanding of COVID itself and COVID politics. Maybe many of you have seen this. This is one of the very earliest case studies of a restaurant in Guangzhou, China, where you can see the pattern of spread from one table to the next. And a lot of it had to do with just the flow of air through the ventilation system, and adjacent tables, people did not get sick. And so already early on, this told us a lot about how the disease spreads, that it spreads through aerosols, and so on and so forth. We've had many other case studies since then. The choir practice in Washington State, where 52 out of 61 people got COVID. So that told us singing and projecting in a closed space is not a good idea. We have a case study of 2 hairstylists who both had COVID, but none of their 139 customers got COVID, and those 2 hairstylists were wearing masks. So that tells us about the importance of masks. And we've had also early on a case study in China that showed asymptomatic transmission. So a lot of what we already know about COVID has come from case studies. Now, we have lots of preliminary data about COVID outcomes and some of the early economic consequences. We have growing data on COVID policy attempts. There are a few databases that are coming into existence, although we need to get better about timing these because they're coming into existence and going out of existence as states open up and then close down, and so on and so forth. So I want to focus on COVID policies as the dependent variable here, although I'll sometimes give into the temptation to focus on COVID outcomes and effects. So there's lots of potential independent variables here, learning from earlier epidemics that applies to later ones, as Marcus and others talked about, also Christos. Political leadership or lack thereof has never been more important. Inequality of all kinds that some of our panelists have mentioned. Partisanship is a huge variable here in the United States, as Jay mentioned. One study shows Democratic governors were 3 times more likely to impose lockdowns. We still have to be careful. There could be some selection effects of which kind of states elect Democrats may be also the ones more likely to do lockdowns. Federalism has never been more important, not just in the United States, but in other countries. If you crack down in some places but not others, you're just creating reservoirs for the disease. Gender, there's some early indications that some countries led by women have done extraordinarily well, although there are also mixed evidence. Some other countries like Belgium, led by women, have not done as well. Medical resources have turned out to be not as critical to outcomes as we might have guessed. A lot of it comes down to communication and policies and leadership rather than just having brute medical resources around. And finally, authoritarianism versus democracy. We've seen both kinds of systems do well or badly, but the ones that seem to be doing particularly badly are the populist democracies, the United States, Britain, Russia, and Brazil. There's a very active debate as to whether the populists are going to be able to turn COVID politics ultimately to their advantage or not. We'll see in the coming months. There's lots of comparisons we can make. Jay touched on some of these. We can compare countries. Obviously, the US is doing much worse than what we might think of as its ordinary cohort of comparators in the European Union. We could look for outliers also. The US, again, clearly an outlier, but there are others. Chile has a very high number of cases. Maybe Jay could say something about that. He knows Latin America well. Some other countries that have very high rates, Peru, Brazil, a lot of the Gulf countries where they have a lot of migrant workers and very high inequality is probably a factor there, I suspect. Sweden is very different from the other Nordics. They sort of let the disease go and they've had a much higher death rate and case rate. And we also have a lot of big countries with low case rates, New Zealand, Korea, China. Even though China's literally blindsided because they were the first to experience the disease, they cracked down very quickly and so have had much fewer cases than the United States, even though we had months of warning to see this thing coming. Some of these countries, it may be that they just have a low testing rate, so they actually have a much higher rate of disease. This comes back to some of the points Jonnell was just making about, the data and the way it's collected also reflects inequalities and isn't always reliable. We could compare United States states. Some of these had a single early peak and some of them had 2 peaks. So Louisiana in particular, even after having a very bad first episode, you would think that that would have made people much more cautious, but evidently didn't. The first episode was partly related to Mardi Gras, but we've had a number of other states that have had a second peak now. Others had just one big peak. Some of those were early. The states that had more travel to China, Rhode Island, Massachusetts, Connecticut, New York, New Jersey. Others had a later peak. We hope it's only a single peak, Arizona, Florida, and Texas. We have some states with very low rates. They're not the ones you might have predicted. You might not have predicted Maine or West Virginia, Vermont, New Hampshire have very low rates, Oregon and some others. And we have lots of states with high rates, as I mentioned, some early high rates and some later high rates. There are many other comparisons we could do of different cases, different federal states and other countries, different counties within the same federal state, different cities, as Jay was mentioning, different businesses in the same industry, different schools or universities. We're also already seeing universities taking very different approaches to this. So I would say also, we should trust some of our prior knowledge and some of our Bayesian reasoning. Here's an interesting little go-round I had on Twitter where somebody said, well, there was an early study that just 5 cases of people who were extremely dire circumstances. They were on ventilators and they were the type of cases that had a very high death rate. And when they were given convalescent plasma or plasma from people who had had the disease but recovered, they had a very high recovery rate. And so some people were saying, well, that's interesting, but it's only 5 cases. To which my reply is, okay, yeah, a randomized controlled trial would be nice, but can I please be in the treatment group and not in the control group? Because I'm a Bayesian and we have 100 years of experience that convalescent plasma can be an effective approach to a lot of different diseases. And so that plus the process tracing on these 5 cases that were almost certain to die is enough to tell me that I'm going to take a chance on that. Whereas some other things, ingesting Clorox or putting UV light into various bodily orifices, I'm going to put a pretty low prior that that's going to work, even if you had some cases that seem to be consistent with that. So we shouldn't forget what we know. And we can learn also from individual cases. We can generalize from individual cases. I've just recently written a chapter on this that's forthcoming. And in fact, in that chapter, I used epidemics. I finished writing it back in November, and I used epidemics as an example. And one of my conclusions was the most interesting and strongest generalization emerged from the international response to the 2014 Ebola outbreak is that the main bottleneck internationally was not finances or capacity, which would require financial investments to fix, but authority and cohesion, which require political attention to address. And so even from those episodes, well before this current pandemic, just studying those, and back to Christos's work too, where he's clearly studied this, you learn about things. In his case, he mentioned Ebola and how the cultural practices of treating the bodies of departed loved ones were a transmission vector for the disease. You can learn a lot about those interactions, and the disease may be different, but there will be some parallels to the politics and to the cultural reactions to it that will help guide your responses. Okay, let me end it there. We've got some questions already that Ben has been sorting through and for the panelists. So,
I'm gonna sort of kind of combine or paraphrase two questions. For grad students, as of the whole panel, for grad students and early career researchers, how would you advise balancing a clear research agenda or dissertation timelines and incorporating questions about COVID into your current research plan? How would you balance long-term career planning with adding to knowledge of the current crisis? Are there any examples from your own advisees and how you've dealt with this question?
I can jump in that, and if others want to, remember to unmute yourself. I finished my dissertation, which was on Soviet foreign policy and military interventions in 1989, 1990. And there were a lot of things going on there in the Soviet Union. And in some ways, for some people, that led to a crisis of their research because it seemed to either invalidate what they were saying about the Soviet Union or make it less interesting or less important. I was fortunate that sort of made my argument more true, more important, and we had more access to evidence. But you can't predict fads. Clearly, coronavirus is big enough and will be with us long enough that it's not just a passing fad of interest. But you got to pick a topic that's going to maintain your interest for a long period of time. Clearly, there's going to be a lot of people studying this. We have already, even a month ago, 20,000 unpublished papers on COVID. I'm sure it's far more than that. So you have to ask yourself, can I really add more? Do I have some special insight to this that I can add more than all the people from all the different disciplines and all the different methods that I can add to this? And the answer may be yes. I mean, maybe you're working in a country and already have some basis there, as Christos was mentioning, that you can really put that to use and turn to the topic of COVID. But it's going to be a crowded field, and if you've got a good topic already, even if it's facing challenges for, say, field research during COVID, you want to give a good hard look before you sort of shift too radically to just chase the latest thing that everybody's talking about.
You mind if I jump in for a moment?
Sure, go ahead, Jay.
Great. So I would say, there probably is room for some books in political science and sociology about COVID in particular. That number is not going to be, 40,000. Most of the research that's specifically about COVID is going to be a little bit outside these domains. And most of the research in the social sciences that's about COVID is going to be article research rather than book research. If you have a dissertation topic that you're really interested in and you want to do it, I think you should probably try to find a way to stick with that. That doesn't mean you shouldn't grab a side project. If there's an interesting idea you have about COVID, go for it. Just think of it, articles have never been more important on the job market, and arguably dissertations and books have never been less important. There's a shift in the balance between those. So having side projects that might lead to a publication in a year or two is really valuable, even if it's not your main project.
Did others want to jump in on that before we go ahead, Marcus?
So just for I was trying to put my dissertation proposal in the spring of 1989, when the communist world was coming down, and so we all sort of thinking we're going to do something on that topic, and then we encountered this so-called moving target problem, right? It's very difficult to write a dissertation on a topic where you don't have specific outcomes. So that is sort of one of the challenges of plunging into a very topical but fast-moving and fast-changing topic. And so what I ended up doing is I ended up studying democratization in a historical context, right? Where I knew what the outcomes were and then could draw some analogies from that towards the present. And that got me interested into comparative historical analysis.
Okay, Ben, maybe we should move to another question.
So that's a question for Dr. Kreuzer. Comparative historical analysis often benefits from a long period of time between the event they study and the time in which they are studying it. What are the theoretical and methodological tools available from CHA to study an event like COVID-19, a critical juncture perhaps, while it is occurring?
Okay, well, that's an interesting question. So yes, I mean, if you have a long time perspective, right, it allows you to ask very different sort of questions. So with respect to the COVID crisis, right, if you had long patterns of pandemics over the centuries, it would allow you to place the current COVID crisis into these larger sort of patterns and ask yourself, to what extent is the current COVID crisis different from the Spanish flu, or and then sort of explore to what extent different contextual factors influence and help us understand these different patterns of which the pandemics spread. But the question about the specific COVID crisis, the principal tools there are the ones that I alluded to in my presentation, is just trying to figure out what is going on, trying to find some sort of patterns, gain some sort of understanding of what the processes are. And then invariably that sort of processing gets you to where Andy was pointing to. I mean, it's sort of these case studies that then give you certain conjectures and theoretical insights, and then you start moving from description to sort of explanation. So it's really, it's the early stages of this research cycle, I think, where qualitative method and comparative historical methods play a very important role. And, you know, you worry less at the moment in testing and coming up with clever research designs.
Let's see, Ben, we had a couple more questions. Why don't we get all the questions on the table, because we're running short on time.
So only one more question that we have in the chat. A question for Christos. An example of COVID-19 ethnography that's available now for reading or for consultation? You're on mute still.
Christos, remember to unmute there.
Sorry. Yeah, there are short pieces available. I mean, there is no proper ethnography, of course, because, as I said, ethnography takes a long time to conduct, and then, well, obviously it needs time to be written and reviewed and everything. But there are blog pieces in various sites, on somatosphere, for example, on the UCL medical anthropology blog, on, well, if you read Spanish or Portuguese, the St. Andrews Anthropology department has a lot of studies on Brazil and Latin American regions, but there is no proper ethnography. I mean, something that we would call proper ethnography, of course, because it's too early. And that's the trouble. Now, this is a bit different from the situation in Ebola, which I mentioned. During Ebola, colleagues who were experts on West African experts and experts on West Africa had created this platform, the Ebola Anthropological Response platform, where they uploaded kind of work in progress papers on ethnography so that this would become useful to medics. But you have to remember that this was an exceptional situation where you had many anthropologists specializing on West Africa, which is a very specific region in the world with a very long history of anthropological study, and an extraordinary number of medical anthropologists of the region, because there were people that were studying malaria or other diseases in that region. So there was kind of a group ready, you know, to go there and study things. And it was a cohesive group. It was a group that could engage in meaningful conversations because they had been in conversation about diseases in the past. Whereas now we have a much more diffuse situation where you have everyone wanting to do some sort of ethnography of COVID-19. I mean, that's the kind of the problem we have, or the situation we have in anthropology. Everyone is you know, seeing this as an opportunity, or they think it's their duty to do it, but they don't necessarily have the training for this. They don't necessarily understand the basic notions or methods of medical anthropology, and this is leading to a lot of noise, if I may be excused, a lot of noise. And it's, you know, I don't think this is very helpful. You know, people would not be jumping into writing, I don't know, ethnographies of economic crisis or of terrorism if they were not experts on the subject. But for some reason, a pandemic seems to be allowing everyone to say whatever they want about it, which, you know, I'm a Democrat, and yes, of course, everyone can say whatever they want, but that's one thing, and writing a paper and producing a proper, you know, scientific work on it has, or should have, other requirements.
Let's see, I see there's also a question in the Q&A that Jonnell already answered, but maybe you might want to add a little bit to that. The question is whether there's research on lockdown compliance, and you mentioned cell phone records, and maybe Jennifer will have a comment on this too.
Yeah, I haven't seen much, and I haven't seen the original studies. I've only read about them in popular media, that using cell phone company records, we can look at where people's pings are coming from and get a sense of mobility in states that have had lockdown orders in place. There's been a good deal of discussion around privacy around that, and better understanding what types of data the cell phone companies are able to analyze and share out. Privacy is protected at the individual level, but we can get a sense of some general patterns of where people are traveling.
Agreed, the cell data is most of what I know about as well, although there is some early survey work that is using methods like list experiment methods, where you don't ask people directly, did you defy a lockdown order, but you include in a list defiance of lockdown order, and you randomize whether some people get the full list or a shorter list, and then use that to back out evidence of self-reported defiance of lockdown orders. And one instance of this that's a working paper that's available is from Horacio Larraghi at Harvard. It's on his website. So if you wanted to have a look at a first attempt at something like that, we're getting a little more information there too.
And I've thrown into the Q&A a natural experiment that uses the cell phone data, and this event where I think it was the Wisconsin Supreme Court completely unexpectedly threw out the state's lockdown order as unconstitutional, and everybody thought that wasn't going to happen. And so it was this surprise, and then we can see a big change in cell phone records from one day to the next with respect to that. So that to me is really interesting and shows an angle at this for sure.
Great. Well, we'll end on that note. Thanks to all of our panelists. Thanks to all the students who attended. You know, there's a very quick cross section of the Institute, but I think you can see a lot of these methods which you would learn in more depth. Hopefully we'll see you next year at Syracuse. And just a final reminder, there's our final panel of the 4 tomorrow on COVID politics. So thanks again to everybody. Thanks to our staff. And you can get the recording of this in I don't know, a week or so. We'll put it up on the web. Thanks to everybody.
Thank you.
Bye.